Hey, Priyanka, as we start to enter the webinar, I know that you wanted to make a few comments just with updates regarding EMRA and the board, and now would be a perfect time if you're able to now.
Sure. Yeah, sounds good to me. Can everyone hear me?
I can hear you.
Okay, perfect. Hi, everyone. My name is Priyanka Lauber. I am a current PGY3 at Lehigh Valley Hospital in Pennsylvania, and I'm the EMRA Board of Directors for EMRA, and I'm also one of the board liaisons for Critical Care Committee. And I'm also the editor-in-chief for EM Resident, and here's our new edition, so check it out. So I wanted to start out by thanking each and every one of you guys for being on the front lines of this pandemic, whether you're at an overwhelmed hospital like my colleagues in New York City, or a place that has been fortunate to not have been hit hard yet. The country is appropriately grateful to have each and every one of you guys on the front lines. I think when we look back to 2020, despite all its tragedies, this will be the year emergency medicine as a specialty proved how valuable it is to society and medicine. So let's jump to the EMRA board updates. So in addition to education through committees such as this, 1, we partnered with ASAP to make sure you have the PPEs you need. 2, we heard that residents are getting quarantined and appropriately are worrying about graduation. So we talked to ABEM, and who is now exercising more leniency for graduation. Number 3, we've worked with a variety of organizations to prevent medical merit badges from affecting your ability to practice. And number 4, for residents like you, myself, to allow us to continue to be able to care for our patients, including the ones that have COVID. And number 5, worked with ACGME to allow Zoom virtual conferences to count as grand rounds time, and ensured duty hours were protected in the emergency medicine declaration. So medical students, EMRA has not forgotten about you. We also recognize that medical students have been impacted by this in multiple ways. Match day, away rotations, it's been very stressful. So we've thus held 2 big Zoom webinars that have featured our board liaison from CORD, which is Council of Residency Directors. This webinar addressed flexibility with upcoming application cycle, away rotations. We've had over 1,000 medical students attend, 1,000. So check these webinars out. I will post these links into the chat after my update. So that's what we've done so far. What's on the horizon? We recognize that telemedicine is going to be a big part of this pandemic and beyond. So we're looking into ways to improve telemedicine training for residents. We're following the conversations about hazard pay for residents, and we're keeping our finger on the pulse. Don't worry about that. We've been following that very closely. We've been discussing that, and we'll be actually holding a town hall soon to discuss that as well, to really understand what our membership is thinking about it. We're also working with ASAP in regards to the CARES Act funding. I'm not sure if everyone knows about the CARES Act. There was the 3rd COVID bill that was passed a few weeks ago, has $100 billion funding for healthcare workers. the first 30 billion was already given out, and it went to all providers. This was regardless of whether you were the front lines or not. And just so you know, that's about 6.1% of last year's Medicare funding. So ACEP opposed this because, we felt like it shouldn't be given more prioritized to the EDs and the ICUs. So there's still a remaining 70 billion that's yet to be given out. So it's important for us to advocate at this time to make sure the resources go to the front line. To that extent, EMRA and ACEP are doing we're doing our annual health policy primer. It's a boot camp. I will also post that link. It's April 26th, 3 p.m. to 5 p.m. It's free. Sign up, get to know more about healthcare policy. We would love to have you there. And so every year, LAC is held in DC around this time, and LAC stands for Leadership and Advocacy Conference. It's a chance for residents, medical students, attendings alike in the awesome field of emergency medicine to advocate for ourselves and our specialty. This year, secondary to COVID, it's been held virtually, which hopefully means more people can attend as we don't have to travel. So I will post a link below for that as well. So that's all I have for my EMRA board liaison update. I try to keep it short, but I wanted to let you guys know how much we've been working on the background. Thank you again for the Critical Care Committee for putting this event together, and thank you to our membership for being present and involved. You are the reason we exist as an organization. So any questions, feel free to email me or message me during the chat function, okay? Thank you.
All right, thank you for that. So my name is Sean Hickey. I'm a emergency medicine resident at the Sinai Elmhurst program in New York City, and I'm on the Critical Care Committee. So I'd like to introduce you to our panelists who have so generously give us their time to talk about what's been going on in their emergency rooms. So first, introduce Dr. Chad Myers, Emergency Critical Care at Elmhurst, Dr. David Cherkis, Emergency Medicine at Elmhurst, Evan Liebner, Emergency Medicine and Critical Care at Mount Sinai, Dr. Ashika Jain, Emergency Medicine and Critical Care at NYU, and Dr. Cameron Kyle Seidel, Emergency Medicine and Critical Care at Maimonides Medical Center. So to start this off, I think that what we'd like to do is just kind of get an idea of what the emergency rooms were like when the pandemic really hit. Can you describe what initially happened, what failed, and how did you adapt? And Dr. Cherkis, if you could start this off.
Sure. It started as a trickle, and then all of a sudden it became a flood. And the biggest thing at the beginning was we had a plan that was designed for a surge of patients that was maybe 10%, 20%, 30% more than our usual volume. And we were imagining, I think, that most of the patients that came in wouldn't have coronavirus, which is kind of how things start. First there's one patient who seems suspicious, and then everybody gets gowned up and gloved up and goes into the room, and then you realize they don't have that, and you take your gowns and gloves and throw them away, and then you find somebody that has it, and then you find somebody else that has it, and you're like, geez, we should make a whole section of the emergency department that can handle these patients. And you start trying to put people there, and then you have a trauma patient that comes in who has no symptoms at all, and they obviously have coronavirus. And then you have another one, no symptoms at all, and they obviously have coronavirus. And 10 minutes later, you realize your entire staff is being exposed, and all of a sudden everybody has it. And so a trickle became a flood very, very quickly.
And can you explain how the Elmhurst Emergency Room changed their workflow and design to accommodate this?
Sure. So we started with the design of the emergency department was 2 pods, an A pod and a B pod, which are basically identical. Main emergency department, a critical care area, and a fast track area. And so when we started, we had a handful of negative pressure rooms. Our plan was to use those for the patients. As soon as they got overwhelmed, we scrambled to turn one of the pods into a COVID pod. And as soon as that got overwhelmed, and the critical care section got overwhelmed, we turned fast track into a second ICU. Eventually, at one point, we even turned a third space into a third ICU. And at some point, the entire emergency department was all basically a COVID hot zone. And it was just a progression based on arrivals and need.
Dr. Jain, can you tell us about what it was like at NYU?
Yeah, I think we've all sort of had a very similar experience. There was a lot of planning when this first started. H1N1 wasn't that long ago when we had to figure out how to cohort our patients, and along similar fashion, sort of figuring out quickly where can we cohort. And so similar to Dr. Shering's experience, that for the first couple patients, you'd get all gowned up, and it was a big production for every single patient that came in, and you have a conversation with infection control about whether or not to test them and things of that sort. And very quickly, it became apparent that the assumption is that patients have it as opposed to don't have it. And now, similar to you guys, our entire ER is essentially negative pressure system. And then very quickly realizing that patients leave the ED and they have to go up to somewhere, and very quickly turning units on the floor, whether it was floors, step downs or ICUs, turning them all into negative pressure spaces, and ramping up sort of very quickly across the hospital at all of our institutions, essentially.
And Dr. Kyle Seidel, can you explain to us the MIMO experience when this occurred?
Yeah, I mean, it sounds like the New York experience was very similar. I think initially what is hard to understand is initially you want your ER to function as it usually does. So we have a critical side and a less critical, and you're expecting a massive flow of these unique patients, but you're expecting you can somehow function this within your current system. And it would make sense because you're also expecting GI bleeds and so forth and all your usual critical patients. And so they should be in the resuscitation area. And I think initially we did have difficulty with that. Part of it is, I think, in New York at that time, I'm sure everyone else agrees, we had a tremendous difficulty with diagnostics. Now it seems like, years ago that we had to call like the DOH for every patient and try to figure out who we were going to test. It seems just a whole different reality. And I think it was a very stressful time. For some reason, it is highly stressful to move between a possible COVID patient and a non-COVID patient. I think part of you feels bad. You feel like you're infected the other patients. And it really, in some sense, did feel like that until we just decided that we just needed to overhaul the entire ED. And so we moved our entire resuscitation area. The critical side became the COVID side. And I think that when you get to a level, you just have to, at some point, accept you're going to overhaul everything. And I think that was the first step, because once that happened, we also had to sort of overhaul our entire staffing model. And we, everyone's vacations were kind of taken away, and we created a surge capacity where at any time we could triple the amount of staff we had, within a couple of hours. But I think it's sort of preparing for that overhaul and being willing to do it that was sort of the big change. And then the next major thing, which I think we didn't understand at first, was that we would have to keep some of these patients in the emergency department much longer than we were used to, because we ran out of ICU beds, and we very much embraced high flow, and there's just no real other space for them in the hospital. That really the ERs, unless they're in an ICU, and most of the ICUs were full of intubated patients, there's just nowhere else to keep them. And so then we created a whole team to keep people in the ER for 7+ days, but I think that initially accepting the initial overhaul was the big first step.
Mm-hmm. Dr. Liebner, you've been working both in the emergency room and throughout the hospital as an RT attending at Mount Sinai. Can you describe what it's been like from your perspective?
So I think we had some similar experiences. I think we kind of rolled out our surge planning in phases. When we first started, they had a big push. We converted our outpatient urgent care center, which is based in the hospital, into a surge space. And so all the well-appearing walking well got funneled over there to kind of separate the patients from the ED. And then while that was going on, we converted our OBS unit, which was a 27-bed OBS observation unit, into a resus critical care 14-bay area and then a 14-bay step-down area, and upstaffed with additional attending resident and PA coverage. We're very fortunate at Sinai where we're able to put high flow and BiPAP patients on the medicine floors. And so it was an entire system hospital-wide initiative. And so normally we can put high flow and BiPAP on the floors, but the medicine teams rapidly turned from the couple of 10 or 15 medicine teams that they had to 48 different COVID teams, almost the entire hospital, except for a couple of small floors, became COVID units. And all the ICUs were converted into negative pressure rooms for the entire hospital and are having 2 patients in each ICU bed. We rapidly upstaffed our critical care attendings, and we trained a whole slew of other providers, cardiology, surgery, anesthesia, residents, fellows, and attendings to help us staff our additional ICU spaces. And so it was a kind of entire hospital system-wide move. And so we have an intensivist-led rapid response team with the 24-hour-a-day coverage of an ICU attending, as well as 1 or 2 NPs, a critical care nurse or 2, and a respiratory therapist. And so we were going around the hospital bringing critical care anywhere it was needed, and we would see patients on BiPAP on high flow sitting on the medicine floor who a month ago would have been intubated and who are now sitting on the medicine floor with the medicine team managing. And so it was a very rapid learning curve that became scary at times.
Okay, and Dr. Myers, not only have you been working in the emergency room, you've also been working in the ICU, and you're one of the trauma directors. Can you explain, your perspective on how things have changed?
Yeah, so I think Dave, honestly, Dave answered, pretty completely in terms of, how we approach things at Elmhurst. To be totally honest, I mean, like, for the last month I've been in the emergency department. My only experience with the SICU actually just started 3 days ago, right? So I've been up there for the week. This is my week. So it's sort of interesting because our volume's tapered off in the emergency department, but it's still, honestly, there are still a lot of vented patients scattered around the hospital. And like Evan was saying, we've basically turned what we have, I think, for around 30 ICU beds at Elmhurst to something like 100. ICU beds. Now, not that all those are staffed by, full-time intensivists. But, we also have something at one point, I think we had 150 patients on ventilators, where at the beginning of this, at the end of February, we had 40 ventilators total in the whole hospital. So you can imagine, I mean, that's obviously a huge strain in terms of trying to find personnel to be able to manage those patients. So it definitely took a huge culture shift in terms of the way to approach these patients. And it strained, I think, the personnel upstairs as well as downstairs quite a bit.
All right. Thank you all for your perspective. So moving on to the next question, and after I ask a question, I'd like for you guys to dialogue amongst about yourself. So the initial recommendation was to perform early intubation. Most people I've talked to have started to move away from this. When did you guys move away from the early intubation strategy, and what caused this change? Dr. Seidel, since you've been so prominent talking about this on Twitter, why don't you start?
So I I guess one can say fairly rapidly, sensed something seemed wrong, and it actually happened with one of my, initial patients. And I really think that ER doctors are in a perfect position to see this extraordinary thing, so it really happened when I had a patient. I started taking them initially pretty far on high flow, accepting that, Italy has great critical care doctors and not thinking that I would necessarily achieve a greater success than them. And from what I read, their success was about a 70% mortality. And so we took, patients far, and we saw what most people have now seen, that if patients are provided with enough oxygen, they often don't have evidence of respiratory fatigue. And I think it's an important thing to sort of understand the difference between respiratory fatigue when we talk about respiratory failure. So the patients I was seeing did not exhibit signs that their muscles were tired and they could no longer breathe. And later, after I learned about gadnonia, and I'm sure we'll talk about that, but if someone is breathing 40 times a minute for a day on and off, it suggests that their compliance is not too bad, because it's sort of just a natural law of the respiratory system that your compliance, your work of breathing is inherently tied to your compliance. And so I had a lot of people come around and say this person's work of breathing was very severe, and yet if our patients were coached, they could take deep breaths, and they just didn't exhibit signs of respiratory fatigue. And that was sort of the initial thing, but it really became it came out of the experience, which I do think is extraordinary in my own history, of being extremely perplexed and being extremely confused, and really going back and forth about when I was going to put a breathing tube in, when I was going to intubate the patient. And because I didn't have any innate feelings, and I feel like I've worked long enough to understand when I should, something just seemed absolutely wrong, and something seemed out of the ordinary. And that was sort of the beginning of my sort of trying to understand what the model of this disease is. So for me, I sort of quickly came to the conclusion that the model we were working under, which is a model that we're treating a alveolar filling process, or sort of a classic ARDS, seemed to be slightly incorrect. And because the mortality of intubation seems so high, and because we got to know these patients so well before we had to make this very distressing decision, I quickly, and because we had success initially with patients that would have been intubated. And by that, I mean, we took patients off the floor that were going to be intubated and put them in our ICU, and were able to take them far enough on high flow that they weren't. Now, some were. So it was a very confusing time. But I at least started very early thinking that an early intubation strategy, without giving people the opportunity to avoid what could be a devastating intervention, seemed wrong.
Any of the other panelists want to give their opinions on this?
Sure, Sean. I think, like Cameron said, some of it makes some sense. I think we really quickly realized, for both seeing the patients downstairs and upstairs, that there are a lot of patients who were hypoxic and were not having increased work of breathing, weren't tachypnic, and looked comfortable. And initially, the early intubation and the kind of trying to intubate them and put them in the ICU seemed like a great plan, but it rapidly became overwhelming, both in terms of number and resources. If every person that we had on high flow or BiPAP in the hospital were to get intubated, there's no way we could even consider managing all these patients. And then second, seeing these patients on the floor, doing 3 or 4 days as a rapid response attending in a row, you'd keep seeing the same patient you'd go to, and you'd see them breathing 20 times a minute on BiPAP, very high settings, but we're comfortable, we're having full conversations with you. And you're like, looking at them and you're like, I don't think you need to be intubated. You're not in respiratory distress. If it gets worse, if your work of breathing gets worse, then of course you'll get intubated. But kind of trying to find that balance, that bar kept moving further and further down as we got more and more comfortable looking at these patients. And so it was a combination of both experience and kind of necessity, because the resources to intubate all these patients would have just been astronomical. That I think a lot of my colleagues kind of decided that to give people chances on BiPAP and high flow. So we've been aggressive with both, kind of using BiPAP, high flow, CPAP. And so some of the patients get intubated, some of them do better and just kind of stay stable and hopefully get better eventually.
Yeah, I mean, we had kind of the same experience also, and I think we kind of shifted over on the early side to a more aggressive anti-intubation strategy. And part of that was resource related, and part of it was when you look at the really grisly mortality and morbidity associated with the intubations, because being intubated for 3 weeks and paralyzed for several days on end is really, really bad for patients. If you can avoid that, then that's a really big good. Living is also a big good. And so trying to balance those is a little bit difficult. And then trying to figure out what the physiology of this disease was early on, I think was very, very challenging. And imagining that it would be something that could just be managed the way Gattinoni described, taking patients that had 2 liters, 4 liters, 8 liters of oxygen, and then jumping to intubation seemed precipitous. And we've had plenty of patients that have required a lot more than that you can nurse through. But then the second question after that was, okay, so we know some people can make it through without being intubated, but who? And is there a way to figure out which patients we should be intubating kind of on the early side, and are there a group of patients that would benefit from that, and which patients are going to make it without getting intubated, and is there a benefit? They obviously have a benefit from avoiding it.
Yeah, I mean, I think, similar to all of you guys, 2 months ago, 3 months ago, there's no way that any of us would be sitting in front of a group of residents telling them that it's okay to breathe at an O2 sat of 86%. And that person doesn't need to be quickly intubated at some point. And that's sort of what was happening in the beginning, right? Like someone would show up and they were breathing at a rate of 40 and they had an O2 sat of 86. And so that's just that's the dogma that we all live under, that person needs to be intubated quickly, except, similar to all of you guys, we were running out of ICU beds really quick. We were running out of vents really quick. And even the temporizing measures that we've all learned, sort of adopting high flow quickly and adopting non-invasive very quickly, but then running out of those resources too, and then sort of really settling into being comfortable with someone breathing at 86. And I think that's something that I don't think a lot of us are still comfortable with, but something that we've had to become comfortable with. And I'll tell you, I've been home for the last week with COVID, and checking my own O2 sat that goes down to 82 whenever I walk around is a really weird concept when you're watching it on yourself even. And that's, I think, how all of this is developed for most of us is it's not normal. None of this was ever normal. This is not something that we had ever dealt with before. And we still don't completely understand it. It changes every time we think we understand it, which is also the interesting paradigm of this disease process.
To sort of dovetail with what Dave said, it's sort of the same institution. I have to tell you that, over the course of the month, our approach to this and what we observed changed pretty drastically. And we definitely, from the get-go, I think we were pretty, strong advocates in terms of trying to delay intubation. I definitely had my first few days of patients where we intubated, aggressively. And I have to say, some of my good outcomes were with those patients. So in a lot of ways, I'm not entirely sure whether or not I'm still convinced that I know the best way to manage these patients after a lot of what I would experience, what I would probably say is a lot of experience, in a pretty large patient population. I also know that I did a lot of chart reviews, with a convenient sample of probably over 100 patients who were non-invasive. And I will tell you that a vast majority of them were intubated at some point during their hospitalization. And that is something to take into consideration as well, is where that patient's going to end up going and who's going to intubate them, and if they're in a setting in which that's a safe place. And we definitely sort of looked at this long and hard and tried to make these decisions as pragmatically as possible. And I'm still not sure at this point that we made the right decision in a lot of those patients. I had to say, there was the sort of the observation that patients do really poorly once you intubate them. But at the same time, I saw a lot of patients in chart reviews that did very poorly when they weren't intubated as well. So this is a difficult patient population. Some of what I think I've observed is that perhaps we probably maybe we're sort of focusing a little bit too much on the intubation and ventilation strategy in terms of outcomes. I don't know yet. I'm very interested, obviously, in looking at our own data and looking at outcomes of patients that were intubated aggressively versus those who we saw a more delayed approach to. But I don't think we have the data now, and I'm not necessarily convinced I know the answer. I will say one thing that we sort of really struggled with as well, and this goes back to the Gattinoni data, and I think we'll talk about that more later, is that it was this concern, and this is from Gattinoni as well, that we were letting people injure themselves by basically allowing them to breathe spontaneously, right? This idea of the spontaneous or self-induced lung injury, right? That these patients that were really breathing hard, respiratory rates of 40 with a really increased work of breathing, that they were actually injuring themselves. And I think a lot of my colleagues at Elmhurst would agree that we definitely think that we observe this sort of process and physiology in real time. And that letting these patients struggle and work, even though their O2 saturations were acceptable on non-invasive, maybe wasn't the best idea either. But I think that still, I think there are a lot of questions that we don't have answered, and I'm not sure if we're going to necessarily have those answers.
Dr. March, could you just briefly explain the observations from Gattinoni and the different phenotypes, just for make sure everyone's on the same page before you guys continue?
So, I hope I don't get myself in trouble here, but I'll tell you. So I'm a huge fan of Gattinoni. I mean, the guy's been publishing about ARDS since the 80s, right? Like he's sort of the grandfather of this whole thing. But I'll tell you that I think his observations, while they're really valuable, and I think a lot of them, there's a ton of truth in them, there's also been a lot of confusion that came from those papers. And part of that had to do with, as far as I know, I still don't think there's an actual official publication yet, that out of all those letters and editorials, they were all pre-press. And if you look through from the early parts of March, there's been a lot of changes that have gone on in these different sort of iterations of letters that are in some ways completely different from the previous iterations. And I think they've actually caused some confusion in the community in terms of the physiology of what's going on. So I will say, if you are interested in the Gattinoni sort of physiology and these phenotypes, the most valuable source is the Carabota lecture from the European Society of Intensive Care Medicine. And I think that's the one that's probably the most complete and that's probably the most valuable. Some of the editorials that were sort of pre-press, they're quite a bit different in terms of the way they describe the phenotypes and the way they describe the effective therapies in them. And again, I think these are sort of important observations, but I also don't know whether or not they're the end-all be-all in terms of like a sort of an approach and a strategy. So the different, just at its most basic, the different phenotypes, the L phenotype and the H phenotype, L being was the low elastance, sort of high compliance phenotype that we oftentimes see in the patients very early in their sort of hospital course, right? These are the patients that in the initial sort of editorials he stated were basically not going to be responsive to proning, which is an observation that we've all seen was not true. Later on in the Carabota lecture, they basically suggested that that was a mistake and that these patients do respond to proning. The H phenotype is for high elastance or also low compliance. So the stiff lungs that we see typically in patients with more traditional ARDS physiology, right? Patients that de-recruit very quickly, patients that have stiff lungs, patients that need relatively high sort of PEEP requirements, etc. And these were the patients that initially he said were the patients that would respond better to proning and sort of traditional approaches. Now, some of the other recommendations that he used in keeping with the physiology, I'm not entirely sure whether or not we were potentially effective or helpful in these patients. The idea of liberalizing tidal volumes in patients that it's been sort of interpreted by some to abandon ARDSNet sort of recommendations on the ventilator. I'm not necessarily sure. I'm convinced that that was helpful and or beneficial for these patients. I could be totally wrong. I think that we're still sort of in the dark with a lot of questions in these patients. I will say that in terms of this idea of sort of self-injurious, the self-induced lung injury, I think that's something that's probably one of the more difficult sort of components of his theories, but also one of them that I think the physiology is sound. I think the theory is sound, but it's based on only theoretical observations, right? If you look, I encourage people to sort of look through some of the publications from Gattinoni previously. He's published, editorials on, sort of spontaneous lung injury associated with spontaneous breathing. A lot of it's based on Burchard's observations as well, but it's all theoretical. And a lot of it is based on small case series of patients who had sort of similar abnormal respiratory drives, namely in patients with salicylate poisoning, who have basically a disproportionate respiratory drive to the respiratory failure. But these were case series, and they're small, and they're from the 80s. And it's hard to know whether or not that's convincing enough to let me know that that's a way for me to completely change my approach to patients with respiratory failure. With that said, I think that we try to approach this from a pragmatic perspective as much as possible. trying to delay intubation as safe as extent as possible. And I'm hoping I'm able to look back and say that was the right strategy.
All right. Does anybody want to respond?
One thing I'll just say about the early intubation, why some of the numbers I think might be difficult to kind of take apart is there does seem to be a severity of the disease, which at least from my bedside view, I have not seen any elixirs or medications that seem to necessarily alter that course. Perhaps we're giving the medications too late or at the wrong timing of the disease. But I do think even for us that some, of the better outcomes were patients that we intubated early, but it may very well be that they had less severe disease. What we said going into, our kind of full embrace of high flow, what I expected was about 30% would not have to be intubated, and I hope to shave off the days of the others. And I think that's about what we're seeing, and maybe a little bit better even. But I do suspect that, some of those patients that we would have intubated and did intubate early, possibly the ones that did better are the ones that may not have had to be intubated in the first place. Now, it's very, hard to know if that's true. So that's, I think there's going to be a lot of difficulty in sort of parsing out the information that's just inherent from that process.
Yeah, let me just kind of agree in some ways with both of you, and that is, from my initial plan was to try and not intubate as many people as I could avoid intubating, knowing what their course was going to look like from all the other descriptions, and that turns out to be true. I mean, on the other hand, some of the people I intubated early did well. Some of the people I intubated late did well also. What I found myself doing more and more was trying to figure out, can I pick apart which of the patients are likely to do well, or I guess to go back to what Chad was saying, which of the patients seem to be at risk for self-induced lung injury, and what does that look like? And to me, that was kind of the holy grail of what I've been doing for the last few weeks, and that is, okay, so this person is satting 82%, but they look great. They're not their work of breathing isn't fantastically high. They're going to be okay with just oxygen. And the same person with the same numbers who's drawing tidal volumes of 1,000 milliliters per breath, breathing 50 times a minute, is that 50 liters a minute ventilation dangerous, or is whatever they're doing to generate that dangerous? And so when I went back and started thinking about those patients, they kind of, for me, became the group, okay, the first group, I'm going to go ahead and intubate this group early. And they seemed to do pretty well. And my sense of that group from before was that they had done not as well on the less aggressive approach. But I mean, it's such a difficult thing to try and study, because the disease is so kind of inherently both variable and bad, even within a single patient's course.
And just adding something to what Dave was saying, I think, we definitely saw a lot of the same patients, and we sat at the bed, in the foot of the bed, talking about these patients quite a bit, and sort of had some shared observations. And one of the things that I think both of us saw, and correct me if I'm wrong, you disagree, but a lot of what I thought was this sort of self-induced lung injury seemed to be disproportionately affect the young and fit, right? We saw some patients who walked in the door who had basically pneumomediastinum, pneumothoraxes, pneumopericardium. I think that was maybe even one of Dave's patients. Where these patients who were fit, young enough to really, really draw and create really strong negative intrathoracic pressures, were able to actually injure themselves. And in a lot of these patients were some of them later on during our experience, even if they had basically O2 requirements that weren't exceptional, we had a strong strong consideration in terms of intubating them to get them through that without injuring themselves and try to rest them on the ventilator. And I don't know if I'm sort of if you'd agree with me in that regard, Dave.
No, I certainly would. And in fact, I mean, we have a very young patient population of sick patients compared to the data. And I mean, I think we made the same observation, which is these young people, particularly early on, who looked like they were going to be okay, and they were all what we were kind of imagining were Gattinoni's type L patients, all progressed and ended up with ARDS physiology as we let them ride, because they were just killing themselves, is what it seemed like. And so I at least personally shifted over to intubating them more aggressively and felt like the outcomes improved with that plan in just this one kind of narrow subset of patients.
Can I ask if you let them ride on high flow or on CPAP or BiPAP?
Both.
Yeah, definitely in both.
Because one thing that I have found, and I've come to believe, so we don't use CPAP anymore where I am, and I tend to believe that for this particular disease, that high flow is far superior, and part of that is we've seen a lot of high flow patients now, and very few of them tend to take large breaths, which suggests that they're not exerting that same negative inspiratory force that we see when we did put patients on CPAP. And I think when this is sort of at the heart of what Gattinoni is suggesting, and I think it's something that's hard for us to look at, but I think we all do see this transition from L to H. And he raises this question, whether this transition is a natural evolution of the disease or is in large part due to pressure-induced ventilation injury. And more and more, I'm becoming convinced, seeing these patients come from the ER door and for days staying with us. And obviously, we can't measure their compliance, but it is just an inherent sort of natural law that if they are able to breathe for 40 minutes or 40 times a minute, they go up and down for several days without exhibiting fatigue, that their compliance must be good. So I see very little transitions to an H-type physiology on high flow, but I saw it pretty consistently when we put patients on CPAP. And so, I am increasingly convinced that some of the classic ARDS and the transition to a low compliance stage is due to ventilator-induced lung injury. And I want to be clear that that is not to say we can avoid it. We are tasked with preserving life, and we need to figure out, and at times we must, every time you put someone on a ventilator, you risk lung injury. And I think in some cases, in order to achieve a acceptable PaO2, we have to do it. And then we have to risk lung injury in what I think are especially fragile lungs, and we have to try to heal them, as we do. But I do think this is one of the questions which is difficult for us to look at and difficult for the medical community to look at. And it certainly could be wrong. But, one of the reasons we try to take people as far as we can on high flows, we want to know that we've reached a point where we are prepared, if that's true, to induce some lung injury and to heal them through it. And I think we're talking about 30% that we're aiming, to save from that process.
The problem with that argument, I got to say, is that people seem to be really willing to kind of pick and choose what they want to believe from Gattinoni's sort of theories. And part of which, if you read, it's this idea of self-induced lung injury that's related to the patient's work of breathing. And that it's not necessarily going to be worsened. That strain on the lung is not worsened by CPAP. And in some ways, it's probably actually improved by patients who are getting pressure support or even BiPAP, right? If you're talking about the real injury as these transpleural pressures and these basically transpulmonary pressure gradient, that's where the injury comes from. That non-invasive therapy would actually improve that. And in his papers, he's basically recommending, looking at, transesophageal pressures, and if it's larger than, I think his number was 15, to intubate them and paralyze them, right? Which is very different than I think the interpretation that a lot of people are having in terms of sort of delaying intubation. And I also have to say that, the transition to H, these age types, I'm not necessarily seeing. And even in my brief time up in the SICU, I've got patients that have been on ventilators for weeks and weeks, and their compliance isn't terrible either. So, there's a question: am I not seeing the H type because the patients were intubated early? Was it different? Was our practice different in that regard? I don't know. But in the compliance issue is interesting because I'm seeing people with relatively high compliance very late, even in their hospital stay. I gotta say, all the patients that I intubated in the emergency room, I don't think I ever saw a compliance that was much less than the high 20s, right? So these aren't necessarily people who have this sort of, I'm not seeing, for instance, my own sort of anecdotal experiences, I'm not seeing a lot of patients with this low compliant sort of ARDS physiology. With that said, the patients that have been the sickest that I've seen in the emergency room, the ones that decompensated the quickest, were the young patients, right? The patients that really crashed and burned, the patients that I was doing everything I could to keep them alive in the ED, the patients that I put on nitric oxide in the emergency department, those were relatively young patients. And I'm still convinced that this may have something to do with the self-injury, and maybe it's a hyperacute self-injury in the sense of sort of a negative pressure pulmonary edema, and you put it on top of whatever's going on from a sort of physiologic perspective with the viral illness itself, that just makes them almost incredibly or almost impossible to oxygenate. But again, these are relatively small numbers, and I think, I hope that we ever get the answer to this before before we're done. But I'm not convinced I'm gonna have that data.
I would say I think our experience is similar to Chad's. We're using a lot of high flow, we're using a lot of CPAP and a lot of BiPAP. I know I'm careful when I'm setting up the CPAP settings to make sure that they're not taking huge volumes, but I find that before I intubate people, if they're somewhat comfortable and have increased work of breathing and tachypnea, I usually will give people trials of BiPAP or CPAP and watch and see what their work of breathing and their respiratory rate does. And if they come down and settle out, there's been numerous patients who I've spared intubation and who will their breathing gets better with a little bit of PEEP and positive pressure on the CPAP and will settle out, their work of breathing decreases, and they do well on the BiPAP mask. The question is, how long does it take, and if they can be weaned off? I think it's a little bit hard to say, but I definitely agree that we use high flow, we use CPAP, we use BiPAP, and I think they're all reasonable and helpful if they're used correctly.
Just a related note to dovetail with the one thing that I think, and I'm reluctant to say Gattinoni was wrong, but one thing I think is difficult is the idea that the compliance in the L-type patient's lungs is terrible, kind of suggests that they're not recruitable, but they're completely recruitable, because if you leave them on, you'll take patients that are on a non-rebreather, 80, 85, 90% oxygen, and put them on 5 of PEEP and 40% oxygen and improve their SAT pretty regularly. So there is a recruitability component, even in the high compliance state, however you describe that doesn't totally make a whole ton of sense to me, at least, or at least it's difficult to understand.
I agree. I don't think it's I don't think I'm convinced enough to be able to put people into such narrow categories so quickly. I think I've had enough patients in the ED and in the ICU who fall into all the categories and don't fit any of the pictures. I've had people who seem like they would have low compliance and they wouldn't do well, who magically respond to a lot of the therapies, whether that's while they're intubated or not intubated, whether that's on high PEEP or low PEEP, on varying different types of ventilator modes, sort of standing at different patients' bedsides in different ICUs, and playing with ventilator settings. And no one fits a picture. And I'm a little bit hesitant to say that people fit into these two broad categories. I think that there's a lot more to it. I'm not convinced that we understand enough about this infection yet to really adopt that theory that there really are just two subcategories of this. I've had people who I agree with what Chad is finding, that a lot of the younger people are the ones who have the self-injury processes, all the pneumomediastinums, the spontaneous pneumothoraces, those are all in the young people, and probably for that very reason. Again, I don't think I believed a lot of this to some degree until I had it myself, and I find myself standing here taking these big, deep breaths, sort of an air hunger that I can do because I'm young, as opposed to the 80-year-old who probably can't necessarily take that big, deep breath. So there, I definitely have found the exact same, at least age paradigm in that theory. But for a lot of the other stuff, I'm not sure that I've been able to sort of find categories for patients along the way. I'm still not convinced I completely understand it at all.
So moving on, and thank you, Dr. Jane, for being the example that you could be satting 80% and look fantastic. So there's discussion so I know Dr. Kyle Seidel is only using high flow, or mostly using high flow, but for the rest of you, how do you determine CPAP versus high flow? Because I know as a resident that sometimes I look at a patient and I say, I think high flow. And sometimes I look at a patient and say, I think CPAP, but I don't really know. I'm just kind of, I guess, making it up a bit as I go along. So what's your experience? And also just for the people listening in, if you want to write any questions down in the chat function, we'll be addressing them at the end.
Also, part of the reason we're only using high flow is because I think if we were able to put these patients in the ICU, I probably would take them further on CPAP, but just in the ER, we found that there's just a lot more chance for error of that mask coming off. And from my experience, these patients become 100% dependent on that life-sustaining oxygen device. And so that's part of the reason. I think that we've just had more success. We're like taping these high flow masks down, and so we were able to keep people on for a week. I think maybe if we were able to have an ICU or have better nurse to patient ratio, maybe I would further consider it.
Is there a concern for, in intubated patients, there's a concern of hyperoxemia? You generally don't want to keep it too high of an FiO2 if you don't have to. Do you think that there's any component of that for people on high flow or non-invasive?
So I got worried about this more recently when I was giving a lecture, and one of the hyperbaric people that was listening to the lecture said, "Oh, that's why everybody's getting pulmonary fibrosis who comes out of the ICU with COVID, because they're all on massively high FiO2." And what I hadn't realized kind of up to that point was there's a difference between hyperoxia and hyperoxemia. And I always kind of worried about hyperoxemia, which is, a high arterial oxygen tension. We know that's bad, but hyperoxia is a high fraction of inspired oxygen. And when it gets up over 80 or 90%, or maybe even up over 70% for a long, long time, you certainly have, a ton of animal data, but some human data that suggests you end up causing an ARDS-like physiology. And, you damage your type 2 alveolar cells, which are producing surfactant, and those seem to be the cells that the virus is attacking directly also. And so, one of the, I was kind of initially, over the first couple of weeks, I moved from a fear of causing hyperoxemia closer to a fear of causing more pulmonary stretch. And then as I thought more about this, I think they're both risks, and I think they need to be balanced. And so that was my big change in the last couple of weeks, was trying to balance those two problems.
Jason, mute your Zoom.
Sorry, I don't know if anybody heard me there, but just really trying to balance those two issues. I feel like we're kind of between a rock and a hard place. There's not a really perfect answer, but at least trying to spare people being on high inspired fractions of oxygen with carefully or judiciously used PEEP, which high flow basically creates relatively small amounts of PEEP kind of the same way. that CPAP does, and that seems to be pretty effective.
Yeah, kind of going along with Dave, we sort of had this conversation, back and forth by email with Scott, and it was sort of like the discomfort I've had with this sort of idea of like oxygen is, these patients need oxygen, abandon the PEEP tables, etc. There was a time where I'd walk around the emergency room and everybody would be on 5 of CPAP and 100% FiO2, and my concern is that really a strategy that's safer than the strategy we've always taken, which is trying to minimize the fraction of inspired oxygen, right? And again, the human data is not great, but the animal data suggests that if you put a rat and make them breathe 100% oxygen, they'll die in a day or two, right? Whether or not that happens to humans or it affects them the same way, it's unclear, but it definitely seems to be a risk as well. So the concern is, are we injuring these patients by our sort of vent strategy, or are we injuring them by hyperoxia? Those are questions that we don't know the answer to. And I know from my entire career, I've tried to minimize the fraction of oxygen that I'm administering these people, to give them appropriate amounts of oxygen that they need. And sometimes you have no choice, right? Like sometimes you've got a patient on 20 of PEEP and they need 100% oxygen to be able to get their O2 saturation over 80. Or over 70 or 60 in some regards. So sometimes you have no choice. But to say that like 100% oxygen and 5 of CPAP is safer than 8 of PEEP and 75% oxygen, I don't think anybody can say that. And that's a question that we just don't have the answer to yet.
All right, and then some of the residents, so some of the questions are, do any of you guys who are utilizing both high flow and non-invasive have a criteria on who you put onto high flow versus
For me,
go ahead, Evan. Sorry.
No, you go first, Chad.
I think, I love high flow, to be totally honest. It's great if it works in the patients. Sometimes patients they need more positive pressure. Honestly, there are a handful of patients just failed not high flow. I think the big deciding factor for us is we just don't have that many high flow units. By the end of this, we had like 165 ventilators in the hospital, right? I think we still only had 10 high flow units. So part of it is just the availability. Initially, there was also the droplet dispersal issue, right? We didn't want to necessarily put everybody on high flow because we thought potentially it was an infectious disease risk. I think, retrospectively, it probably didn't matter. We put a mask over the patient who's on high flow. It probably made no difference compared to a patient who had a CPAP mask that they were removing, or it was leaking, or whatever. I think either way, there are probably advantages and disadvantages. But to the most part, I think it's approaching each patient individually and seeing how they respond to the therapy, right? If you put them on high flow and they look comfortable, that's great. You won. That's like the endpoint that you want. But some patients do better on non-invasive, and some patients look comfortable, or less comfortable on non-invasive.
Yeah, I was kind of going by how they looked. If they were pure hypoxia but were comfortable, I was more willing to kind of start them with high flow. If they were increasing worker breathing to KIPNIC and really kind of working, and I thought they were rapidly heading towards intubation, not just with hypoxia, I would be more kind of leaning towards BiPAP and CPAP to give them a little bit more positive pressure and recruit them. I'm not sure we know what the right answer is, but that was kind of my kind of decision tree.
Yeah, I think we've tried having decision trees and algorithms to figure out which one to start. And quite honestly, a lot of times just with our volumes, it's which one do I have available fastest? Which one is which one is closer and which one do I have access to faster? And so that's sort of been our idea. I think similar to you guys, if someone was more hypoxia, trying to find one versus the other. We avoided non-invasive in the beginning, I think for similar reasons that you avoided high flow, that we felt like that was the more aerosolizing version, and that we would have to put them into separate isolation rooms if we wanted to do non-invasive. And at some point realizing our volume, again, was just too high to even do that. So a lot of it is, while there is an algorithm and there is a decision tree, It's really which mode do I have available to me, and even adopting things like 6 liters of nasal cannula with the non-rebreather on top of that. Trying to sort of be creative with all different modes of oxygenation and ventilation, just given our volume issues.
So can anybody tell me what their criteria is for intubation? And then just back on that, how have you changed how you intubate? And what do you do now for failed intubations? And what are your backup strategies?
So we very early sat down as a system at Mount Sinai, and anesthesia, critical care, and the ED for a system-wide approach sat down and created a policy and protocol for how we were going to handle intubations. At Mount Sinai, in the main hospital, we were fortunate to have priorly developed a difficult airway response team, which is activated throughout the entire Mount Sinai hospital, and they're working on rolling out through the other community hospitals. But in terms of for difficult intubations and failed airways, we can activate our DART team, which for the COVID epidemic has an in-house 24-hour-a-day ENT attending, an anesthesia attending, CRNA or senior anesthesia resident, plus our critical care team. So if it's in the ICUs, it's the ICU attending. If it's on the floor, it's the rapid response attending. And so we'll rapidly get additional resources at the bedside. And that's kind of how we've been approaching our failed airway. In terms of approaching our intubation, we try to do them in negative pressure rooms if available. If not, we do them wherever the patient needs. We're not going to delay a life-saving procedure. We're strictly using video laryngoscopy, trying to keep us as far back as possible, using N95s with face shields, pure rapid sequence intubation with the ventilator set up prior to intubation, so we can, once the tube passes the cords, the balloon goes up and they get hooked up directly to the ventilator to minimize disconnects. There's HEPA filters on all the ventilators. We have an extra HEPA filter with us in the room that we don't open if we need to bag the patient potentially. And so it's been working pretty well. And then we've developed kind of an airway team where the critical care team has either senior anesthesia resident or CRNA with us. And so we've been working collaboratively in conjunction for the upstairs in the ICU. And the ED, we have either 1 or 2 ED attendings plus a senior resident doing all our intubations with the DART team available as a backup.
We've sort of kept ours very separated. The ED sort of manages the ED intubations. Having ramped up our negative pressure ability, most of these patients are already in the negative pressure parts of the emergency room, so we can really be intubating in any of those rooms. Everyone's in individual rooms. They may not be a closed door necessarily, but they have their own sort of at least curtained off space. And then we have a very clear algorithm in terms of, so you're ramped up with some version of a non-invasive mode of oxygenation and ventilation, and you failed that at some point, and therefore there was a decision to intubate. And then there's a very clear sort of plan A, plan B, plan C, just like any great airway plan should have. And for us, the biggest sort of paradigm shift was to not bag really at all, to minimize bagging. And keeping that, if you were already on high flow, keeping high flow on during intubation as passive oxygenation, and then in between attempts, if we needed to have multiple attempts, to use an LMA as your mode of bagging in between, essentially, and moving away from bagging again as much as possible. Similar to you guys, where your HEPA filter is already on. As soon as the tube goes in, you go directly onto the vent and tidal CO2. So that's your sort of mode of confirmation at that point. But really the biggest change for us was adopting LMA in between all of those.
We largely did a similar kind of thing in some ways in terms of adopting video laryngoscopy and doing things wherever we could. But one thing that this actually kind of changed for me is these patients are incredibly fragile, and it's really common, particularly patients that you've let ride a long, long way down the rabbit hole who now need to be intubated. As soon as you take their breathing away or pull them off a CPAP mask or high flow, they desat to 30%, 15%, and they desat fast. I mean, a minute is a really, really long intubation for these patients. And so one change that this caused for me is I've gone back to using sucks. It's much, much faster than rock. It doesn't make much difference in the vast majority of patients that we see. But the big difference is the difference in onset is maybe 20 or 30 seconds, and patients breathe in those 20 or 30 seconds on the rock very weakly. And on sucks, they go from breathing to completely apneic basically instantly. And I think it has made it safer since I made that change.
So, this is probably one place where Dave and I sort of disagree. I gotta say, so I've gone both ways, sucks and rock, for induction, and I'm not entirely convinced that the sucks is always the right answer. And the one thing to be prepared for in sucks is that you have to be extremely aggressive about post induction and intubation, sedation, and analgesia. These patients, if they wake up before you basically start and get them adequately sedated, when they start struggling, especially the young ones, they will decompensate extremely quickly. And this sort of goes back to that idea of the negative pressure pulmonary edema and the self-injuries, lung injury. It is amazing how bad these patients do when they start fighting the ventilator. So in some ways, the rock is nice. As long as you can get the tube in before they desaturate, significantly, that delay in terms of paralysis, that's the between sucks and rock, that's the disadvantage. But it is sort of an advantage to have a patient paralyzed for an hour where you can get them adequately loaded with sedation, with the prop and fentanyl or whatever it is that you're using, so that by the time it wears off, you've got them sort of comfortable. Because if they emerge from induction and they're not adequately sedated again and they start fighting, these are the patients that really, you took a sick patient and now you've basically got like a peri-code patient.
Let me agree with your disagreement, because I left one thing out, which is absolutely everything you said I agree with. As soon as I pass the tube, I'm giving the patients 50 of rock. So I'm using the sucks for the intubation, but I'm actually paralyzing everybody with rock afterwards. Not with the full 100, but with half dose, which is enough to facilitate exactly what you described, because otherwise it really could be very, very dicey.
Yeah,
I agree with Chad. I'm using rock pretty much on everyone. I'm very rarely using sucks. But what I'm doing is most of these patients are failing BiPAP before I'm intubating them. And so I leave them on the BiPAP machine. I'll turn up the set rate on the backup rate on the ventilator. And so the minute that I'm RSIing them, I will keep them on the BiPAP machine and let them breathe almost as a non-invasive ventilator at 30 times a minute. And so they will stay fairly well oxygenated while the 60 seconds pass. And then I'll turn off the BiPAP machine, take the mask off, and intubate from there.
One thing that's actually also kind of interesting, obviously having an entire country who's out of work is, it's basically got a lot of time for engineers and designers to sort of help us out with this. We've got a lot of things like, sort of novel equipment. The Pratt School of Design created a bunch of airway boxes for us, which was really interesting to sort of put to use. And they're basically, for the most part, they're like a splash guard made out of plexi with armholes. So we've gotten to sort of use these different sort of devices and sort of minimize our own sort of risk and exposure. Some with better sort of results than others. But yeah, for the most part, I use non-invasive for pre-oxygenation, especially during that sort of post-induction, not quite paralyzed period where you're just basically maintaining a little positive pressure. Even with that, these guys desat almost instantaneously, oftentimes before they're fully paralyzed. So you have to be definitely prepared to go in there quickly. VL, I love the hyperangulated blades with the idea that I'm basically minimizing sort of airway opening, so that these patients are sort of like collapsed, and I'm using a rigid stylet. It seems to be sort of safe, and I've had a pretty good, experience with that. And then I tend to transition them directly to the ventilator after intubation. And if I actually, of all the intubations, I lucked out, knock on wood, no one had to be reoxygenated in terms of bag. If I were to need that, I would use an LMA, just like the other colleagues said.
I think one thing we did at least is we got ourselves protected a little bit better, and as sort of thanks to our hospital. But I think that from the beginning to now, we have just a little bit better protection for ourselves. Now, we only have one negative pressure room in our entire COVID side, and it happens to have a very small window. So we actually don't put a lot of patients in there that are dependent on the oxygen device. So we have a tremendous amount of high flow just scattered around the ED. And I think to some extent we have sort of accepted the risk, but also we've just tried to sort of protect ourselves better. One thing initially we were trying not to bag, but again, they do desat pretty quick. And we are trying to have our residents also do the intubations. And I think you do become acutely aware of that lag time of the SAT, which every once in a while you become aware of. And I find that if you ride them far, and even if you ride them not so far, they really just, their physiology, they tend to desat. So we do have an LMA, and we have done that. But, I have started to just say, if you don't get the tube in 10 seconds, we have a viral filter in a bag, and we're fully gowned. And so give a couple of, gentle breaths and then look again. So we're not really, at least when I do it, I'm not waiting to see the SAT go down to 40, hopefully, because very few of them with apneic, even with apneic oxygenation, will not desat within 10 seconds. So I think the biggest thing, which I wish everyone had a PAPR, I wish I had a PAPR, but I think once you feel more protected, you feel much freer, and it becomes less highly anxiety ridden if you know that whatever it is, whether it's an LMA or bagging gently, whatever you can do is sort of in the armory of what you would usually do. It just is it's sort of a much more secure feeling.
Dr. Myers, so once you get past, you actually have the tube in and they're intubated, what is your ventilator strategy? Are you going with the classic ARDSNet strategy, or are you using something else?
Yeah, so it sort of depends. Typically, especially at the beginning of this, I was just using ARDSNet, low tidal volumes, lung protective strategies. As we moved on, I actually started seeing patients who very quickly in the emergency department, I was seeing basically moving straight up the PEEP ladder in terms of I had a patient within the first week after we started seeing really a huge patient surge, where I had him on I think a PEEP of 22 and an FiO2 100%, and he was satting in the 60s. And that was the first patient in which I used APRV on, primarily as a rescue, and had amazing success with that patient. I actually switched him over to APRV and was able to, one, wake him up, down titrate all of his sedation. He was actually awake in the emergency department. And this is the same guy who I had on a PEEP 22 a couple hours before. So I sort of had that experience, and then very early on sort of transitioned over to APRV almost entirely for almost every patient that I've had in the emergency department since. Now, the way I've actually applied APRV has sort of changed over the course of this as well. As part of this has to, again, going back to the idea of sort of self-induced lung injury and trying to minimize how much work of breathing, because things like APRV, which are like a permissive sort of ventilatory strategy where you let the patient breathe spontaneously, you'll see these patients on APRV where they're just pulling huge tidal volumes on top of your PIs. And I was a little concerned that I was actually allowing the patients to hurt themselves. So at that point, I basically talked to Nader Habashi at Shock Trauma, and as well as Evan sort of put this call together, and we sort of he introduced me to this idea of a sort of a rapid cycling, very short high time. He calls it TCAV at this point, where you're using very short high times to improve bulk ventilation. And in some ways, it basically sort of suppresses most of the sort of spontaneous breathing in these patients. And I've had some pretty exceptional sort of results using APRV in this TCAV rescue strategy.
Yeah, I'd probably agree with you a lot on there. So I frequently am one of the few intensivists who very quickly turns, even before all this started, whenever we had patients with ARDS, I would employ pressure control modes over volume control modes, and often find that I had much better success in general with them. And so along the same lines with this, for as much as we teach ARDSNet, I'm a full believer in pressure control modes that do better a little bit in this. And so in the ED, I tend to put patients on the vent and put them on volume control modes. Again, employing a lot of the ARDSNet protocols, so low tidal volumes, high PEEPs. Our protocol for the ED automatically has people going in at a PEEP of 10 as opposed to 5 as soon as you've intubated them, and that was, again, part of our respiratory algorithm. But in the ICU, where I feel like I have a little bit more control over patients and I know my respiratory therapists a lot more intimately, I have been playing a lot with pressure control modes, including APRV, bivent, whatever you want to call it, and finding that patients tolerate that a lot better, and that I'm able to improve their PF ratios a lot faster and a lot more efficiently on a pressure control mode over a volume control mode in general. And the hardest part with all of that is really sedation. I find that a lot of these patients are dysynchronous, and sedation has probably been one of the hardest challenges to overcome for us, especially in the ICUs. I've got patients, because we're running out of all of our drips too, so they're on propofol and Precedex and dilaudid drips and phenobarbital drips and whatever sort of paralytic we can get our hands on, whether that's an Imbex or something else, because we run out of that too today. So, the part of the ventilator strategy is also a sedation strategy, and that's probably been a little bit harder to actually control, to actually get people to a place where I can ventilate them better.
Yeah, actually, to sort of go along with that, I mean, that's clearly one of the most challenging components of these patients is sedation on the ventilator. And that is also, again, one of, I think, the main advantages with the strategy like APRV, where the patients can continue to breathe spontaneously. You don't have to suppress their ventilations because there's no real concern about dysynchrony. I can just keep the patient sedated. I don't necessarily need to eliminate the respiratory drive. And what I've found, my own personal experience, is you can have a patient who's well sedated, RAS of -3 or below, and they will still have a respiratory drive where the respiratory rate is in the 30s, right? Like it's phenomenal. And this isn't my idea. This was sort of one of the statements that Habashi made, is that whether or not this is sort of neurotropism related to the viral infection itself, where the virus itself is affecting the medulla in terms of respiratory drive centrally, and we're seeing patients. That's the reason why these patients are so difficult to sedate, is that it's actually the viral infection itself. Whether or not that's true, I don't know, but it's definitely something empirically that I've noticed, with my patients.
I would add, what we're starting to do more of at Sinai is once we intubate, we drop an OG tube at the same time before we leave the room. And so we're starting to use the gut. So we're giving Oxy 5 or 10 Q6 down the OG tube. And we're even talking about starting to give some PO benzos as well, using a lot of benzo drips, so Versed, Ativan, whatever we have. Same with us, we're running out of, we're worried about running out of propofol, dilaudid, we're out of fentanyl. So trying to make use of the OG tube as much as possible, hopefully will help.
It's really interesting. I mean, I have to, I'd like to try APRV on some of my patients. The few patients I did initially when I was in the ICU, it just seemed that they, right after I intubated them, they just had pretty good compliance and very large release volumes. But what we're doing, I guess we're following the more traditional Gattinoni approach, which is we are doing a low PEEP. And part of what the main thing that is guiding some of our ventilator strategy is I really do believe that hypotension is not in itself a property necessarily inherent to this disease. And if you look at your triage, very few people are coming in hypotensive. And we have patients in New York, as everyone does, coming in all stages of the disease. It just is not, we have patients walking in triage statting 30 and they're, coding before we can get them in the resus room, but their vitals did not show evidence of hypotension. So really what we're doing is we're, putting them on the vent, doing an FiO2 of 100%, starting at a PEEP of, 5 to 7, and then going up as you need to. Now, what I have found, and which is, fairly easy to do, I found that their best compliance is sometimes not at the place where their best saturation will be, which is to say the lowest driving pressures will be at areas where they may be satting 70. Now, in a normal situation, that's maybe where you start to call someone for ECMO. But obviously you can't do that on every patient. So, for a resident at the bedside, what I would suggest is if you, put them on a pressure control mode and you look at their volumes and you have them at a PEEP of 5, to go up slowly on the PEEP and see what happens with your volumes. If your volumes are going up with the same pressure, then you're achieving an area of more compliance, which suggests that you were atelectatic and now you're a little bit higher on the pressure volume curve and your compliance is better. Now, what we've found is the opposite, that as we go up, we get smaller volumes, usually around 8 or 10. And so we kind of limit it at 8 or 10. But often at that point, patients don't have a saturation, which we necessarily feel super excited about. So they may be saturating, 85. And at that point, we just say, make a clinical decision and decide, what you believe is more injurious for that patient to be, satting at, even if it's 79, or if you think we may be overdistending the lung. Now, I found these patients to be exquisitely susceptible to PEEP at times, at least the high compliance lungs when we put them on, that they become very hypotensive. And so if they become hypotensive, and initially I think it was worse because we were keeping them more dry, because that's just what I was trained to do and what we were trained to do for ARDS patients. So I think now we're hydrating them more and we're seeing a little bit less of that very consistent response to increased PEEP. But if they become hypotensive, consider going down on the PEEP. But I think we run into that a lot where we are at a situation where we have them at what we believe is their best compliance. Their saturation is not something that's super exciting to look at, and we have to decide, where we go from there. At least initially, I'm saying try to achieve a SAT at 80. Now, most of these patients were talking to us at a SAT of 80, and if you can achieve a SAT of 80 and you think that's, where your best compliance is, so where you're getting the highest volume for the least amount of pressure, then just watch it for a while. And that's just a clinical decision. And we don't have an answer. I don't have an answer of what, SAT they should be sitting at, but I suspect that if you require a SAT of 92 or even 90 in your most severe patients, there is nothing else that I can see one can do except to use higher pressures, which I have found seem to, in certain patients, which seems to be about 50% or more, to lead to hypotension and to other hemodynamic issues.
Dr. Seidel, you brought up
Sorry, just to sort of follow up on what Cameron was saying. So with APRV, I will tell you the traditional sort of APRV approach where you're using basically long high times, right, over 5-6 seconds, right? You will definitely see large tidal volumes. If you use, and by the mean, what I'm talking about, the APRV TCAP sort of rescue strategy, you can find sort of protocol on aprvnetwork.org, which is run by Hibashi. You're using much shorter cycles, right? You're using somewhere in the range of 1 to 2, 3 seconds max, right? When you use these short cycles, your tidal volumes will shrink considerably. Now, the other thing is important to remember is your release time is extremely important in terms of determining what your actual exhaled tidal volume is. So you have to make sure that you're tailoring your release time to the patient's compliance, to the patient's lungs, right? If it's too long, you're going to have massive tidal volumes, and that could potentially lead to a lot of atelectic trauma and be injurious as well.
Dr. Seidel brought up the question on every resident's mind at all times is, should I give fluids? How much should I give? And why is balanced fluids always the best over normal saline? So can anybody discuss their fluid strategy in these patients? I know in the beginning we were keeping them very dry. But it's kind of seems from my own personal experience that maybe we went a little too dry. So if you guys could just discuss that.
I could just give you my specific number for what we're doing. And this is also in the setting of like a super busy, it's not as busy anymore, but what was a very busy emergency department where, if you say maintenance fluids, you're not necessarily sure if the bag ends, if a new one's going to be hung. So what we were generally saying was just, each shift, which is about 12 hours, if they are not eating and drinking very well, which we hope a lot of patients will, then just to order a liter of isotonic fluid. So they were getting about, and are getting about 2 liters of supplemental fluids about per 24 hours. And that was just an easy way to sort of, when you come on shift, see, assess, and order a liter slowly over 12 hours.
I'll tell you, I think that we ran our patients so dry in the beginning that we ended up with a lot of really bad acute kidney injury, to the point where we had many patients who were knocking on dialysis's door. And that, I think, was one of those awakening moments where you're like, maybe we don't need to be this dry. Dry lungs are happy lungs, but these aren't happy lungs no matter what you do. So why try to make them happy with being dry at the cost of taking out a kidney here and there? And I'll tell you, I've become a lot more aggressive about giving patients fluids. In the beginning, it was, sort of giving them a liter here and there, and really individually sort of watching to see how much fluid to really give. And now I've become a lot more liberal in my practice of giving fluids. The question about LR versus NS, again, like the recommendations were for more buffered solutions, and then we started running out of LR, and so then we went back to NS. And between the two, it really doesn't matter if you're talking about a couple liters here and there. It's when you start getting into higher volumes that those become issues. But some fluid is better than no fluid, and that's sort of become the adoption that I've taken on, is actually giving some fluids to these patients.
Yeah, we had the same experience. I think we were running people just incredibly dry. They would go like 3 days without a drop. That certainly isn't that healthy either. But, we were also worried early on by stories that at least I was hearing from our colleagues on the floors. And that was, you put these patients on 10 different sedatives and find that they became and high pressures and find that they became hypotensive. And so the floor teams were bolusing the patients aggressively. And so they went from being super, super dry to being massively overloaded on the other side. And so, I mean, really, the key thing here is to try and dial this in somewhat. And so you'd like to run them on the dry side, but not bone dry. And the best way to do that is, if you have the time, go to the bedside, take a look at the patient, do a point of care ultrasound, see what their volume status really looks like. And if you have the time to do that, that's really ideal.
Yeah, and I echo exactly what Dave says. I think that honestly, we personally, I think you can tailor your sort of volume strategy to the patient. And I think using point of care ultrasound is probably the best modality in terms of making that. I have to say, I mean, like, these patients, it's amazing. We had, the disfortune maybe of having patients board in the emergency department for days and days, right? So we'd have patients that were on CPAP for 3-4 days and then got intubated in the emergency room. And then you saw them basically, hemodynamically tank afterwards. And so it was interesting to see, obviously, that, while we were considering this to be a disease that we wanted to run dry, obviously we could go too far, keep them too dry. You do an ultrasound, they had complete sort of resporophasic collapse of their IVC, give them some fluid, and they got better. But the counter argument is that there were plenty of patients who were also had a clinical history that they should be dry. You do an ultrasound, you'd see a little bit of resporophasic collapse. You thought it was safe to give them fluid, and it made no benefit in terms of the hemodynamics. So it's definitely, I don't think, a sort of one size fits all sort of approach. Everybody needs to be approached from bringing into account their clinical history, their volume status from a clinical perspective. And then I think really the real answer is with point of care ultrasound.
I'd agree with Chad 100%. I think the more interesting question, I think, of who to give fluids to and how much is we're seeing a lot of patients coming in with a weird sort of DKA, not the traditional DKA that we normally see, but with DKA that doesn't necessarily have that low of a pH, but with a large anion gap, and that takes a while to close. And so I think the tougher question is, normally we would just be pouring fluids into these people. It's the balance of how much fluid to give those people. I think, again, what Chad and Dave are saying is point of care ultrasound, go to the bedside, look at the heart, look at the IVC, and kind of give fluids when you think the patient needs fluids because their volume status is down.
Yeah, Evan, exactly what Evan said. It's interesting. The patterns that I'm seeing a lot of hyperglycemia and DK. Obviously, a lot of renal failure. I think we've already sort of covered that. A lot of hemodynamic instability and shock in these patients, and this is all obviously in conjunction with respiratory failure. But it's clearly this disease is systemic, right? And it's a question of whether or not how much of it is iatrogenic, and how much of it is actually secondary to the virus, how much of it's because of the cytokine storm or whatever. It's a confusing disease process. And I have to say, I mean, anybody who sort of makes a statement that they have it figured out, I think is lying to you. At this point, there's still a huge number of unanswered questions. I'm just waiting to get those answers,
Chad, we're also seeing a ton of strokes. Our neuro IR people are very, very busy with a ton of embolectomies, a ton of COVID strokes, which is kind of an interesting phenomenon, I think.
Oh yeah, and that's actually something we haven't even talked about is the incidence of clot in these patients, which I think is if you were to point of figuring out one thing that's been a drastic change in terms of my management and what I concentrate on these patients is early anticoagulation. And I know Sinai has a very aggressive anticoagulation strategy, and so do we. And I think there will probably likely see a correlation in terms of what's going on with these patients that has to do with either microvascular emboli or even macrovascular emboli in these patients.
I think we're also starting to see some iatrogenic injuries from the anticoagulation. So we're seeing there's been at least a few brain bleeds. There's been some GI bleeds. So I think Sinai, we've gone aggressive with kind of an early aggressive anticoagulation pathway. I think we're realizing that there's some risk, especially to some of these patients with it. And so I think we need to be careful. It's not going to be a panacea and fix everything. And so you really need to carefully weigh the risks and benefits. But we're using Lovenox, we're using heparin drips, we're using some of the NOACs, depending on where they're going and their creatinine clearance, to kind of see where they fit. And kind of it was a protocol that was developed with the system, with critical care, with ED, with oncology and hematology. And so it's kind of been interesting to see how that's evolved.
Can you also all talk about your use of steroids as we're on kind of a topic of medications being used?
So I think one of the hard things with the medications in general, and I know in my institution, we've just, I generally have been willing to do whatever infectious disease believes at that moment is good, but it's hard because initially I think we were using especially all of the sort of special medications like IL-6 and convalescent plasma and so forth, and we may have been using them a little bit too late. And there certainly seems there's a time course of this disease, the mechanisms of which we don't really understand. But I suspect that the viral diseases, we're not getting viral loads, which probably is not present for 16 days. And so when to use these drugs is very difficult. We actually today now are generally stopping using hydrochloroquine and azithromycin unless patients present within the first week of their symptomology, which is fairly rare. And then as far as so we sort of think of it sort of you have the hydrochloroquine, which hopefully decreases, I guess, viral replication possibly, and then your antivirals, and then your anti-inflammatories. And so at least with what we're doing with steroids is we are giving 60 of solumedrol BID, generally when they're a little bit further, like so a week to 10 days into their course, and when they are now requiring high flow or a higher supplemental oxygen. And then it's still, we're trying to come with an institutional sort of policy, but it seems like there's not quite enough data to be extremely confident to do something on every person. But for now, at least we're considering doing sort of a slightly lower dose, although it's not super low, on patients that are sort of, week to 10 days in, and then perhaps when their requirements get higher or when they're intubated or, at that time when you feel like a higher anti-inflammatory effect will be better and you're more confident that I guess the viral a disease is gone to go up to, whether it's 125 BID of Solu-Medrol. But that's sort of what we're doing, is starting off with a slightly lower but not extremely low dose for those mid-range patients.
We're kind of starting most patients that in the ED or anywhere on the floors that are getting escalated to increasing oxygen. So top-down non-rebreather, high-flow BiPAP or intubated. In general, we're starting 0.5 mg per kg BID of methylpred with 5 days and then tapering it. But I've been talking to some of the ID and other teams and Pulm that are seeing some of the consults that are on the floors. And they're starting to see some people who have, when they get tapered off the steroids, might have some sort of a rebound effect of the respiratory distress. So I think that might be something interesting that we might learn more about as it sort of unfolds. But that's kind of been the standard that we've agreed to from our hospital.
We evolved a little bit. We started, but we haven't been using methylpred mostly. I think we've been using dexamethasone. And the original rationale there was in terms of not messing up the other fluid management, avoiding other mineralocorticoid effects of the other steroids. And we just kind of stuck with it. Also, it self-tapers kind of nicely compared to some of the other drugs. But we started out using it basically for the ARDS physiology patients. We were giving them 20 milligrams a day. And I think we've become a little bit more aggressive in the patients who are earlier on, but with respiratory distress. So we're talking about giving them 10 or
20. One topic that we skipped over, which has been very hotly discussed, is the proning of the non-intubated patient, or as Dr. Turkis likes to call it, the pig roast. So can you guys describe your experience with that?
We adopted proning really early. We started proning our intubated patients fairly early, and then started proning all of our non-intubated hypoxic patients in the ED fairly early as well. And sort of just getting people to turn themselves onto their stomach and hang out in the ED on their belly, basically. And in the upstairs world, we developed proning teams essentially. So at particular times of the day, there would be a host of people who were on the proning team and would just go around the hospital proning and unproning people all day long, basically. So we found that it helped significantly, and that patients not only tolerated being proned, but actually did exponentially better when they were prone. And you can almost see immediately, within a few minutes of turning them over, how it improves their oxygen requirements, their ventilator requirements change significantly. And for the non-intubated patients, they'll even just tell you, I feel more comfortable. Again, in my own little experiments at home, I have a whole little proning station in my living room that I take naps on, and it's actually really comfortable, surprisingly.
Say we kind of, in the ED, we don't prone anyone that's intubated. I think it's a very dangerous idea. If you lose a tube, you're probably going to kill someone. But we definitely upstairs are very aggressive with proning intubated patients. We, like NYU, have created proning teams. Turned out that there was a lot of OR techs, scrub techs, OR nurses that weren't having anything to do with all the OR shut down. And so they basically made them into proning teams, and they go around. There's some people that go through charts based on PDAF ratios. They're already flagged if their PDAF is less than 100, and they talk to the ICU team, and they have times where they'll prone and unprone. Downstairs in the ED, we're mostly focusing on proning people who are either on high flow BiPAP or just nasal cannula or whatever, but that can do it themselves. So we try not to, it's crowded, it's busy, there's not enough staff to kind of help everyone prone themselves. So we focus mostly on people who can kind of go over on themselves. The nurses are monitoring them, and it's been sort of helpful. I guess we'll see. In terms of people intubated, we'll maybe try to bump them onto their side a little bit, put some pillows behind them downstairs in the ED.
So our experience was very similar, and proning clearly is incredibly effective. But the thing that really struck me early on with the disease is it's not just proning; it's every position change that's really effective at helping the patients oxygenate. So whether it's left lateral decubitus, right lateral decubitus, and then one of our colleagues put a patient in Trendelenburg, which is exactly the opposite of any kind of pulmonary physiology I ever imagined would be effective. And guess what? Their patient sat came right up. And that really struck me. And what I can't fully explain the physiology. I make no claim to actually understand what's happening, because it does not make a ton of sense, but it definitely works, and every position is effective, and the movement is effective, whether the patients are intubated, not intubated, on oxygen, and maybe even people at home not on oxygen. But I definitely think it helps a lot of people.
And in some ways, just kind of go along with what Dave's saying. I wonder whether or not if there's sort of a difference between proning and repositionings, whether or not it's worth sort of differentiating the two concepts, because clearly we also don't prone in the emergency department for logistical purposes in terms of for safety issues, right? I think that's important that you've got an intubated patient. I'm talking about intubated patients, that is, that proning is an incredibly dangerous procedure if not done with the right group of people. And while we do prone patients upstairs, we do have a proning team. It's been very successful up in the SICU right now. I've got a handful of patients that are getting proned for 16 hours a day. And it's done this very standardized approach. It's systematic, they're checklists, and that's what it takes to do it safely. But in the emergency department, even our intubated patients, we were repositioning. And those patients that we were having incredible difficulty oxygenating. So we would put them in, lateral decube. We'd wedge some pillows beside them. Then they would, their O2 saturation would bump. And when it would fall again, then we put them back on their back. We put them like what Dave was talking about. We put patients, head down in Trendelenburg, and you'd see a 10% improvement in oxygen saturation, which is incredible. I have no idea physiologically why that benefits these patients. But it does. So it's sort of this semi-prone or repositioning that we would do, even in both our intubated and non-intubated patients, that had pretty considerable benefit.
Yeah, and we're proning a lot. Probably when I just left the ED today, there's probably 4 or 5 people prone. But I do think it is important, especially in the emergency department, to understand what seems to be a physiologic difference from normal proning when we prone intubated patients in the ICU. And that is usually, you prone an intubated patient by prior studies. If their PF ratio is 80, it might go to 120 to 100 to 150, and eventually above 150, and then you stop. Whereas these patients, especially early in their course, they certainly have a marked improvement in their hypoxemia, but that improvement does not necessarily appear to be sustained. And the only reason, I say that is for us, we think of it more as buying time as opposed to recruiting lung. Which is to say, one of the things that we have when we sign out is we talk about what the day of illness by symptomology is, which is the best that we can do. We say 13 days, 14 days, and if someone is on their 15th day, we'll really be aggressive with proning. But I do think that there is some, so we have this thing where if they, hit these certain targets, we call them priority 1, which is to say that they're high priority for intubation. And even if they improve markedly, if they go to 90, from 81 to 97 once prone, they remain priority 1 because there's a good chance when they're flipped over, they'll go back to where they were. It seems that the disease is sort of still progressing, and I don't know what it is, if it's just a redistribution of vascular flow, which is why it's very different than, in some ways the same as prior proning, but it certainly doesn't appear to be as sustained as it was before. So I think sometimes in the ER, it just, it can be a little bit, especially because a lot of patients are early on, day 6, 7, 8, and it seems like that day 6 through 11 can be pretty rough, that don't get too comfortable. It's certainly prone, but don't get too comfortable if you're proning, a high flow patient or non-intubated patients, and then they all of a sudden have a marked improvement. Because we've had a lot of patients who had a marked improvement, and then, the next day we had to bring them to the resuscitation area on their stomach and then flip them over and intubate them. And so that's just the difference, is that rather than seeing it as, and this is early on in the disease and not intubated patients and not sort of the lower compliance patients, we see it as buying time over recruitment.
So we're getting towards the end. I've actually gone over time. It's been such a great discussion. Just open up to some questions from the audience. I believe Mina has been collecting them. So I'll let him.
Yeah, so thank you guys so much for your discussion. This was incredible. I think there are a few questions, most of which have already been addressed by you all and just within the discussion. Two things for the listeners. One is there will be a recording of today's discussion that will be posted on the website. And two, we are taking notes on the answers so that if you have missed anything, if you want it in text or in audio form, we'll have both of those available to you. One question that was pretty popular that has yet to be addressed is which pre-existing conditions are you all seeing that relates to the highest risk of mortality? I know there was a study, I believe, out of NYU that detailed about 4,100 patients there. They said the most significant risk factors were age and obesity. Is that what you all are seeing, anecdotally at least?
Yeah, for us, those are the two, I think, biggest ones. The patients who I've had the hardest time with and the ones who eventually have coded have been the older and the obese. There's a lot of data in the beginning looking at gender populations. I think that gender population still is a disparity in that sense, but definitely, I think we thought that things like smoking and COPD are probably part of it as well, but by far, I think obesity and age have surpassed a lot of the other predictors.
Yeah, certainly those have been really big for us too. I would also say dialysis patients previously on dialysis tended to be very sick with this. And the diabetics, as I think it was Evan who was talking about, they're just incredibly difficult to manage their diabetes, and they also do much worse than kind of similar age.
Definitely. I agree. Definitely obesity. My sickest patients have all been morbidly obese. And that doesn't say that, not to say that I haven't seen plenty of patients with this that were ill, need to be intubated, who weren't obese, but morbid obesity seems to be far and away my own anecdotal experience, the sort of the worst pre-existing condition. What's interesting about the COPD and asthma is I haven't seen a lot of patients with COPD and asthma. Not a lot of not a lot of obstructive lung disease, and patients that have reactive airways that need to be nebbed or respond to steroids. I don't know why I haven't seen that. Maybe it's just not appreciating it, but I don't know.
I agree. I think the other thing that I've surprisingly seen a lot of, or unsurprisingly, we've had a lot of people with HIV who have had some pretty rough causes, and then also our transplant patients and oncology patients. I think the data is that oncology patients, at the last I looked, if you get COVID and active cancer, it's about a 50% mortality off the bat. So one of the oncologists told me, and they definitely do very poorly. And then a lot of our transplant candidate patients, we've had, I think I've intubated 2 or 3 post liver and kidney transplants within the past that have had recently in the past day or two. And they've also been having a very rough go. So kind of people who are sick, have immune suppression, whether it's diabetes, heart disease, transplants, I think all are having higher risk.
All right, 2 more for you. One is, initially this was advertised, or the information that we were gathering from other countries was that this was a disease of the old and the sick and the chronically ill, and not a disease of the young. However, at least for me, and I'm certain at probably your institutions, we're seeing a lot of young people to get sick. Are there certain comorbidities you're seeing with that? Is there a reason why you think that this is affecting people of all ages, not necessarily at the same rate, obviously? Are there pre-existing factors associated with the young getting significantly ill?
I honestly don't know. I feel like, if they tend to have a higher BMI, but we have a lot of young patients that I have no clue why they got it and others don't.
Okay, and last question here. So moving forward, it's obviously very hard to predict how this will look in the future, but we're getting a lot more antibody tests now, and we're going to find out the extent to which people have already been infected, the extent to which having antibodies makes you immune to a future infection or reinfection or infection from a mutated form of this. So kind of projecting forward, kind of what you guys believe is going to be the future of what COVID is going to look like in the upcoming months, and 2, what do you think we will see in terms of how much this is already spread within the community once we get more widespread antibody testing?
I mean, I know for us in Queens, I mean, I think our impression is that, I mean, the community saturation of COVID is very, very high. Our hope is that that's going to confer some herd immunity to the community, and we're not going to see such a massive second wave. With that said, we do expect that we will, at some point, once things sort of reopen, we will see, another wave. I think a lot of us hope that it looks more like a trickle or a steady stream, and we don't get basically the walls blown off the hospital again. But at this point, we don't really necessarily know. I think we all ask the question of, what an emergency department is going to look like, a couple of months from now, or 6 months from now, or a year from now. I know personally, I don't expect that I'm going to be able to work without an N95 anytime soon. I think I'm going to walk into work every day, every time I see a sick patient, thinking that this patient probably has COVID, at this point. I think, rapid testing may help in terms of sort of minimize that and being able to cohort patients in the right place. But I'm going to assume that at this point, our general approach to these patients until we have an effective vaccine, we're going to basically sort of operate in a very, very different sort of environment than we did, a few months ago.
Yeah, I would agree with Chad. I don't see myself anytime in the near future intubating a patient or being in someone's airway without an N95 and a face shield. And I'm not smart enough to kind of have an idea of what the future is going to look like or what, but I think that we probably have more widespread people who have been exposed than we know. But I'm not sure we're smart enough to know whether or not having antibodies is enough to protect you, or if there's a risk of reinfection, which might be worse. There's some stuff coming out of Korea and some other places that's saying getting reinfected might be deadlier than getting it the first time. So I don't know the answer. So even if I were to have antibodies, I would still wear full protection.
Agreed. I think that, again, it's naive to think that we understand this infection in any way, shape, or form, how it's going to behave, how, there's discussions that it's already mutating, and that's going to change how we move forward with this. And similar to you guys, I just assume everyone has COVID. Our trauma protocols just assume that everyone has COVID. Our MI protocols assume that everyone has COVID. We just assume that everyone that comes into the ED has something and COVID. I've had enough appies who also had COVID over the last few weeks, and so the assumption is that it is rampant within our community, whether we like it or not. No matter how much we try to stay indoors, it is still out there. We can only try to make that a little bit better, and perhaps we're seeing that change a little bit as all of us have sort of described, that our ER volumes have gone down just a little bit. But that's for the foreseeable future, weeks, months, goodness knows, hopefully not years. We will still be wearing our N95s for every patient.
All right. Well, thank you all so much for this discussion. Again, we will post everything that we have both in written and audio form and video form, frankly. I want to thank all the panelists who have agreed to talk. We all learned a great deal. I've received a lot of private messages already, thanking you all for your time. If I did not answer one of your questions that you sent to me privately, I will try to find the answers for them and send you a message back personally. But thank you all for joining us today, both panelists and listeners.
Yeah, thank you, everybody. This has been excellent. Thank you so much for your time.
Thank you.
Happy to be involved. Thanks.
Thank you.
Everyone be safe.
Yeah.
Thank you, guys.
That went really well, Mina, Allie, and everybody.
Yeah, I think so too.
Yeah.
I think
Great
so too.
job, you guys.
I learned a lot.
Yeah, it was very fascinating.
John, thanks a lot for moderating. You were amazing.
Fielding questions. All right, well, everybody, take care. Get some sleep.
All right.
Back to it tomorrow.
All right. I will email everyone the link to when the video is up.
Sure.
And we'll go from there.
Perfect. And we'll spread it to our residencies.
Great. Thank you so much.
Yeah, no,
Right.
thank you. And Val, this is going to, just to confirm, this is going to go on the EMRA website as well.
Yes, and it'll be in a couple of spots on the EMRA website. Todd has done an incredible job of kind of corralling all of the COVID webinars so that you can just go to one main spot and find all of them, but then we'll also cross-reference it from the Critical Care Committee page.
Perfect.
That way you can find it a few different ways.
Fantastic.
All right.
All right. Take care, everybody.
Thanks, everyone. I'm going to go ahead and end the meeting.
Awesome.
All right.
Thank you,
Bye.
Val.
Bye.
Bye.